Hi, this is Saad Al Amri. I'm going to share with you this case of a patient who needed phakic IOL exchange with another type phakic IOL 12 years after the surgery. Surgeries were performed by Professor Jorge Aliu. Our case is for 41-year-old gentleman who presented in 2009 seeking refractive surgery. He was highly myopic with very thin corneas but with ideal anterior chamber angle and depth as analyzed by anterior segment OCT, with completely normal eye examination in both eyes. Professor Jorge Aliu opted to implant phakic anterior chamber angle supported catchet lens from Alcon. Post-operatively, patient was very satisfied with excellent refractive and anatomical stability throughout his post-operative visits over the last 12 years, with unaided visual acuity was 20/20 in both eyes and normal IOP and stable corneal endothelial cell count in both eyes. However, the patient recently reported symptoms of unexplained positive dysphotopsia and stress on how psychologically annoyed by the external reflection frequently noticed by the other people. So, after extended share time about the benefit, risk, and alternatives, plan was to go for IOL exchange with phakic posterior chamber columnar lens ICL Evo Plus from Star Surgical. So, let's start with the case. This is the Acrysov Catchet phakic anterior chamber lens from Alcon. Although this type of lenses have been recalled globally in 2012 and withdrawn from the market by 2013 due to the increase in number of cases of endothelial cell loss among the implanted patients. But again, it wasn't the reason for explantation in our case. Our patient tolerated this type of lens with very stable endothelial cell density and morphology over many years. Surgery started by creating at least two opposite side paracenteses for later ICL haptic manipulation. Viscoelastic was then injected above and underneath the IOL. Cohesive OVDs are recommended with ICL implantation because it's easier to remove, and on the other side, dispersive OVD it might be cataractogenic if trapped beneath the ICL. Then, main corneal incision of about 3 to 3.2 mm was made. As you can see, catchet lens is a foldable one, and it was removed very smoothly. For the ICL loading, it is very important to adhere to proper loading techniques step by step in order to avoid any inadvertent lens damage. The ICL being implanted here is Evo Plus that has an expanded optic diameter with central aqua port. Implantation was successfully done with careful manipulation, tucking the distal haptic under the iris first, with a special care not to touch the central very sensitive 6 mm optic. OVD was then simply washed out using PSS cannula. A single 10-0 nylon suture for the main wound and stromal hydration for the paracentesis was then performed. Followed by injecting prophylactic intracameral antibiotic. Same procedure was done in the other eye without any complications. On the first post-operative day, patient did very well, was very happy with unaided visual acuity of 20/20 in both eyes and intraocular pressure of 15 mm of mercury in both eyes. And that's it. Thanks for watching.